You are at the Ibex Medical Analytics Seminar, and we are really happy to have you here today. I am Dr. Manuela Wexler. I will be moderating this session, and we have a wonderful panel of speakers who will talk about AI in primary diagnosis, going beyond cancer detection. So our first speaker is Dr. Dimitrios Korentzelos from University of Pittsburgh Medical Center, who is an associate professor and part of the GEU Center of Excellence at UPMC.
Hi everyone, small correction, I'm assistant professor. I just started actually. I was previously resident and fellow at UPMC, and I just started this January as assistant professor in genitourinary pathology. And today I'm going to talk to you about routine use of Ibex Galen prostate AI solution for primary diagnosis of prostate biopsies in clinical practice in our institution. As most of you know, UPMC is a huge healthcare provider, but also insurer that is based in Pittsburgh, Pennsylvania, currently operating 40, or at this point maybe more than 40, academic, community, and specialty hospitals, about 800 doctors' offices and outpatient sites, and employing more than 5,000 physicians. You can see the impressive international footprint of our institution on the right side, with currently institutions in Ireland, Italy, Kazakhstan, China, and most recently Croatia. Regarding us in the Department of Pathology, it is a center of excellence. We call it a COE, providing high quality and, as most US institutions, subspecialized state-of-the-art services. We have 18 clinical divisions. I'm in the genitourinary pathology division myself. And in total, 166 faculty members under the UPP, the University of Pittsburgh Physicians. The volumes we process are pretty big. You can see that we are receiving and processing annually more than 200,000 anatomic pathology specimens. The two-dimensional barcode is the key to connecting to our clinical system. We do have 8 Apereo 82 scanners and 2 GT450 scanners distributed in 7 sites. Essentially, we are scanning at this point 1/3 roughly of our daily volume. And this is not distributed across all these 7 sites I mentioned, but across 3 histology labs. The total scan time is approximately 1.5 minutes. And again, we have multiple indications for scanning slides, like, for example, post-sign-out index slides. But specifically for GU, all the in-house prostate biopsies we do digitize. So how does Ibex Galen for prostate work? This AI-powered solution was implemented back in May 2022. We have the glass slides that are digitized, and the algorithm is clever enough to identify the course, and not only identify the course, but also identify serial sections, essentially as duplicates on the same slide. And then it provides the pathology with a series of heat maps, probability heat maps, regarding a series of parameters that we are interested in to incorporate into our pathology reports. Obviously, the most important is benign versus malignant. Then, if malignant, the Gleason grade, automated measurements, presence of perineural invasion, and also high-grade prostatic intraepithelial neoplasia. The initial study, external validation study, is a study in 2020 by Pantanovic et al. Dr. Pantanovic is our chairman right now, that was published in Lancet Digital Health. So let me take you over this table here. You can see 3 different colors for the cases. The ones with the white color are the ones that are called by the algorithm essentially benign. The red ones are called malignant. And then you can see that roughly 1/4 of the cases are called suspicious, so they have this yellow color. Let's go first into the likely benign cases. You can see that 99.3% of the time for cases that were called benign by the algorithm, the pathologist also agreed with benign. There were only 2 discrepant cases called benign by Ibex that ended up getting called malignant by the pathologist. But the important thing is that even in these 2 individual cases, the points of interest that corresponded to the areas of neoplasia, they were still getting to the pathologist through the algorithm. So that gives us a very high negative predictive value. It's 0.99. And then going to the second category, the likely malignant, the red color, you can see that in 98.4% of the cases, there was essentially agreement for malignancy between Ibex and our pathologists. Just 2 cases that were called ASAP, so atypical small acinar proliferation by the pathologist, and the real discrepancy was only in 5 cases, corresponding to 1.3% here. And these were, as you can see, with a double asterisk, mostly cases with florid atrophy-related changes, like, for example, post-atrophic hyperplasia. So with this in mind, we can see that the positive predicted value is also very high. It's 0.99. And then I come to the third category with the yellow color, the suspicious cases. This can go either way, of course, benign or malignant. In my short empirical experience, the benign cases are a lot of cases with partial atrophy in the prostate that are picked up as suspicious. So this leads me to my next point. With such a high positive and negative predictive value, I really trust the algorithm in my daily practice as a screening tool. I don't personally use it as a tool with the intent to diagnose, but as an excellent screening tool, which also helps me to better manage my cases, triage if you prefer my cases, because I will start my day with the suspicious cases, so I can order my PIN4 stains early before our cutoff time, which for UPMC is 11 a.m., so I can get back the stains as fast as possible and minimize the turnaround time for my patients. You can also see on the top the cancer detection had an area under the curve, under the receiver operating characteristic curves of 0.989 with a 95% confidence interval of 0.983 to 0.997, so the performance is really very impressive. Next, we go to the Gleason grading. You can see that roughly 2/3 of the cases had full agreement defined as agreement between Ibex and pathologists with regards to the prostate cancer grade group, the 5-tier system. And there was partial agreement in 28.6% of the cases, meaning a difference just of 1 grade group. Again, my very limited personal experience mostly tells me that these are cases where the pathologist, we might end up calling like 3+4 with a small maybe 4%, but the algorithm has maybe a little more conservative approach, calling it 3+3. The real discrepancy was less than 10% in this cohort. And real discrepancy, I mean at least 2 grade groups. The few cases I've seen were actually cases that there might be a small focus of 5. And what happened was that the algorithm called 3+4, but there was consensus among the pathologists for 3+5. So this would lead to a change from grade group 2, essentially to grade group 4 with some patient implications. But mathematically talking, if we look at the quadratic kappa, which is essentially a chance-corrected agreement metric, it's very high, it's 0.763. So if it's above 0.6, it's considered very fair. And even the interclass correlation coefficient is pretty high, it's 0.75, with a 95% confidence interval of 0.665 up to 0.81. Some other quality metrics, I would call them. So all the pathologists felt confident in providing an accurate diagnosis when they were reporting the slides with the addition of Ibex, as with reporting on the microscope. Productivity, you can see that everyone felt at least somewhat potential, that there is at least somewhat potential to increase the diagnostic efficiency with the use of Ibex Galen. No of the pathologists actually find that the solution was difficult to operate. You can see that most people thought it was very easy to somewhat easy and some neutral. And with regard to the customers, the pathologist satisfaction, which is the user in this case, you can see that there was consensus. 100% of pathologists were satisfied using Ibex, particularly because it provides us those features that are very important for reporting in our prostate biopsy reports, like the Gleason grade, scoring, the perineural invasion, and the automated measurements, as we will see later. So these were some general ideas behind the algorithm, but let's see some practical examples, how I use it and my other colleagues in our daily practice. So when I log in the morning, first thing in the morning in the Ibex website, this is the screen I'm getting with, as we already discussed, 3 types of cases. Cases marked with no color, or if you prefer white color, which are called essentially benign by the algorithm. Cases with red color, called malignant by the algorithm. And cases with yellow color, which, as we already said, they are called suspicious. And again, with such high positive and negative predictive values, I really trust the algorithm for the negative and the positive ones. So I'm still gonna see the glass slide, but maybe I feel more comfortable. But my point here is that I will start my day with the yellow cases, the suspicious ones, again, so I can order my stains fast and decrease the turnaround time for the patients. So, for example, like some representative images from such a case. So, for example, you can see here and here that these areas are busy. And then when turn on the cancer heat map, you can see how it highlights the areas of interest, the cancer areas, and it essentially gives you a probability heat map where the color ranges from blue, meaning low probability, to red, which means high likelihood. And another case of 3+3 here, you can see two foci adjacent here and here with neoplastic glands traversing the core from one side to the other. And when we turn on the cancer heat map, the two areas are highlighted as areas with high likelihood of cancer. And then a different feature, the Gleason heat map essentially here. So in this case, you can see that the upper part of the core is very busy, back-to-back glands, poorly formed, fused, while the rest of the core has also neoplastic glands. You can't really see it like here because it's a low-power image, but more like a Gleason 3. And then when I turn on my heat map, this area with the green-yellow color corresponds to the area of Gleason 4, and the area with the blue color corresponds to the area of Gleason 3. So the algorithm told me that this is 4+3, and I can actually better visualize it using the probability heat map. And you can see here on the bottom the probability heat map for the Gleason grading feature, ranging from blue, meaning Gleason 3, to green-yellow, meaning Gleason 4, to red, meaning Gleason 5. So now you can see all three images together next to each other. The first one is obviously the H&E. The second, actually let's focus first in the right side, is the cancer heat map. Red means high probability of cancer. And the middle one is the Gleason heat map, with the red-yellow color here, meaning that we are probably looking at a prostate cancer case with Gleason 5 and 4. And realistically, if we compare with the H&E here, you can see this area here, plus these areas here with poorly formed cells, either as single cells or small cords of cells infiltrating the prostatic stroma. So you can see like the cases next to each other, the images, how you can see the cancer heat map, and also drive you to the Gleason grading. Another feature that I personally find useful is the perineural invasion heat map. You can see in this area a nerve bundle and how the neoplastic glands wrap around it. And then on the right side, you can look at the perineural invasion probability heat map and how it highlights it. This I personally find useful in some cases where I'm pretty confident there is perineural, but for some reason I have trouble finding. So if I don't find it within the first seconds, I'm going to click the heat map and accelerate my work. And even a case with a smaller nerve bundle here, involved by neoplastic prostatic glands. And here, how it is highlighted by the use of the probability heat map. So this is a useful feature. This is also a useful feature in terms of efficiency in time, and trying to decrease the time per case. This is the measurement, essentially, function. So the algorithm actually gives automated measurements to us, but even if you don't trust the automated measurements for tissue length of the course or for tumor length, you can use like a digital ruler that is inside the algorithm and make the measurements yourself. So again, if I compare this to what I did as a resident, counting with a ruler, this is much faster and probably more reproducible on the long term. Are we there? Can we use it? I mean, we're using it at UPMC, but the thing is that we have a very, very big need, which is unmet, to have specific codes to facilitate the billing for the use of such AI tools in general. So right now, there are AMA CPT codes in an effort to capture the effort that is being put. I think in 2024, there were like 30 new CPT class 3 codes. And we do try to capture the work units, but there's no money flow from the centers of Medicare and Medicaid services right now, which is a little problematic, because although everyone in the US wants to ride the wave and adopt the new technologies that are boosting efficiency and decrease turnaround times, however, the costs can be prohibitive and an impediment on the adoption of these new technologies. So where are we going to the future? Many AI algorithms are developed for using pathology, and this is particularly evident, I feel, in these years. USCAP, where the majority of posters and platforms I saw were around AI approaches, but the reality is that only a small percentage of those will end up actually being used in the routine clinical practice. At UPMC Pathology, we are very actively engaged in integrating these AI efforts, the AI solutions, into our daily, real clinical routine, especially with our new chairman, Dr. Pantanovic. And a perfect example of such an effort and such a deployment is the use of Ibex Galen prostate, which is used at UPMC and helps pathologists to improve diagnostic accuracy and for sure physician confidence. And of course, AI and digital pathology in general can enable the implementation of a centralized laboratory approach. So at this point, I would like to thank both my faculty members, Dr. Deer, Dr. Quiroga Garza, who is together with us, Dr. Pantanovic, the previous fellows that worked on this important project, but also the people in Ibex that are in daily discussions with us in an effort to improve the whole process. And before stopping, I would like to share with you one of my favorite sayings by one of the giants of AI in this era, Andrew Ng from Stanford. Essentially, AI is the new electricity, and like the electricity transformed every single industry 100 years ago, the same thing we're experiencing right now. AI is literally revolutionizing every possible industry, even our industry, the healthcare industry. And I think that we should not hold unrealistic fears in our minds that it will take our jobs and it will remove us from the clinical practice, but we should try to understand it first of all, optimize it and use it in an ethical way, both for our convenience as pathologists, but most importantly, for the better results for the patient population. Thank you very much.
Thank you so much. Wonderful presentation. I invite now Professor Stuart Schnitt, who is the head of pathology at the Brigham and Women's Hospital and Dana-Farber Cancer Center and professor of pathology at Harvard Medical School, who will indeed talk about the use of AI in primary diagnosis of breast.
Okay, well, thanks for the introduction, and I will be talking about breast. Here are my disclosures. So just in brief, why are we even talking about AI in pathology? Well, we know pathologists are too few in number, and we're all being asked to do more, and we're overworked. And much of what we do is relatively straightforward, but some of what we do is time-consuming, prone to inter-observer variability, or prone to error. And AI can potentially address all of these issues and improve our work life. So taking a step back from the last presentation, how can AI help in the daily practice of pathology? Well, you heard some of that. It can improve workflow and reduce turnaround time, level the playing field by increasing accuracy and reducing inter-observer variability and bringing everybody up to a similar level. It can be used as second reads before final sign-out to ensure clinically significant lesions have not been missed, so it can provide a QA function. And it can do things we don't like doing or not very good at doing or are time-consuming, and do things we just can't do, looking at slides on a screen or under the microscope. Now, to get right to the breast issue, this is a paper published by Judah Sandbank and MPJ Breast Cancer in 2022, talking about the development of the Ibex Galen breast algorithm. So this talks about the development of this algorithm for breast pathology detection in whole slide images of biopsies. There was an internal test set and validated in an independent cohort, and it describes the deployment in routine clinical use. So how was this algorithm developed? It was based on a fully supervised multi-layered convolutional neural network and specifically designed to classify and analyze whole slide images of breast biopsies. It was trained on more than 2 million labeled image samples from multiple labs, manually annotated by more than 20 senior pathologists. And the algorithm can identify 51 different breast lesions and pathologic features of invasive and in situ breast cancer and benign breast lesions. Here are the data from the internal test set. You can see that for the detection of invasive cancer, the AUC was 0.998, and for DCIS, 0.999. You can't get much closer to perfection than that. So that's the internal test set. Was this validated? Yes, it was validated on an external validation set of over 400 cases, and for invasive cancer detection, the AUC on the external validation set was 0.99, and for DCIS, 0.98. So this seems to be consistently applicable. How does this work? Well, you saw an example of this in prostate. Here is an example of DCIS on the left with a focus of invasive cancer on the right. If we apply the invasive cancer heat map, it highlights the invasive cancer in red. We apply the DCIS heat map, it identifies the DCIS in red. So this is a very accurate way of identifying different lesions in breast biopsies. Now, interestingly, this same algorithm has now been tested on more than 3,600 cases from 6 different sites. And you can see that most of these studies were done on biopsies, but the last study was done on excisions. But there's remarkable consistency in the ability of this algorithm to detect invasive cancer and DCIS, with AUCs ranging from about 9.8 to 9.9 in all of these studies for both DCIS and invasive cancer. So what are the added benefits of using AI in the practice of breast pathology? Well, it can prioritize cases, highlight clinically important lesions within cases. It can pre-order receptor immunostains for invasive cancer and DCIS, thereby saving time. Pre-order additional levels. For example, if the algorithm is able to detect calcifications, but there are no calcifications in a biopsy, it can order additional levels so you get those more quickly. Judith's study showed that it can eliminate the need for IHC in some cases because it gives the pathologist more certainty about the diagnosis, can pre-populate reports, including synoptic reports, and essentially act as a super resident or super fellow, even for the residents and fellows in the room. You can have your own super resident or super fellow. And all of this will help reduce turnaround time, which obviously is very, very important. So then we know the algorithm is really good at identifying invasive cancer and DCIS. How can AI help in more problematic areas of breast pathology, particularly Ibex galen? So we're going to focus on invasive ductal versus invasive lobular carcinoma and the identification of microinvasion in cases of DCIS. If you want to hear more about Ibex galen's ability to quantify HER2, there will be a seminar like this one tomorrow at noon. So let's focus on invasive ductal versus invasive lobular carcinoma. Well, many of us as pathologists don't think that that's much of a problem. We can tell lobular from ductal carcinomas, right? Well, the fact of the matter is when you look at data from clinical trials, it's not so straightforward. These are 2 large clinical trials that included large numbers of cases of invasive lobular carcinoma. And among cases diagnosed as invasive lobular carcinoma at the original institution, in these 2 studies, only 60 to 66% of ILCs were confirmed on central pathology review. So pathologists do have a problem in reproducibly and reliably diagnosing invasive lobular carcinoma. So how does Ibex galen do in this? Well, pretty well. In 153 cases of invasive breast carcinoma, the distinction from invasive ductal from lobular carcinoma had an AUC of 0.97, quite good. In a follow-up study from Hartford Hospital that was presented here last year using the same algorithm, looking at 180 cases of invasive ductal and lobular carcinoma, the AUC for the detection of lobular carcinoma in distinction from ductal carcinoma was 0.94. So again, this algorithm is really good at doing this. Here's an example of a core needle biopsy with an invasive carcinoma. And if you put on the invasive cancer heat map, as you saw in the prostate, the areas of cancer are highlighted in red. But the galen algorithm also has the ability to tell you whether it's more likely to be lobular or ductal. And if it's lobular, it will be in blue. So we go to that part of the heat map and we see that the cancer is highlighted in blue. And at high power on H&E, you can see that this is clearly an invasive lobular carcinoma. Now, we recently did a study on the identification of microinvasion in cases of DCIS using this algorithm. This was presented by one of our fellows, Jansu Karakis, as a poster yesterday. And in this study, we looked at 147 slides with DCIS from Brigham and Women's Hospital and Champalamo Foundation. Rita Marks, who's the senior author on this poster, provided those slides from Champalamo. 85 of the slides had microinvasion, 62 had only DCIS, but these cases of DCIS these slides with DCIS were selected from the same cases as cases with microinvasion. So they essentially act as, each case acts as its own control among those cases. And I have to tell you that these cases were biased toward really difficult cases, because when we were selecting these slides, Jansu and I were sitting around looking at slides, and I think Rita did the same thing, saying, okay, the algorithm will never get this. So we were trying to bias it toward problematic cases. In addition, the slides were scanned on 2 different scanners at these 2 institutions. And I think it's important to remember that these slides were evaluated using an algorithm that was trained to detect frankly invasive cancers. It was not trained to detect microinvasion. So what did we find? Well, we found that the algorithm detected microinvasive foci with a medium to high likelihood in 83.5% of the cases, which absolutely blew me away when I saw these results. Moreover, among the 14 cases with microinvasion considered by the algorithm to be low likelihood of invasive cancer, after we as pathologists reviewed these cases, the algorithm had in fact highlighted microinvasive foci in all but 2 cases. So really the algorithm was able to identify microinvasion in 98% of the slides with microinvasion. Here's an example of a case of DCIS with microinvasion. You can see on the left an H&E stain section with DCIS on the left side and invasive cancer or microinvasive cancer on the right. And you can see that the invasive cancer heat map highlights this focus of microinvasion. Another case of DCIS with microinvasion, I think it's probably really hard to see the microinvasive focus on the H&E stain section, but if you look carefully at the area highlighted in red by the heat map, there is a focus of microinvasive carcinoma. I don't know why it's up there, trust me. Now, in all honesty, the algorithm also identified microinvasive foci in 5 slides missed by the pathologist and categorized by the pathologist as DCIS only. So that's a real oops. But I have to say I don't feel too badly about that because in these cases, microinvasion had already been identified on other slides. So here's an example of a microinvasive focus missed by the pathologist and picked up by the algorithm. These are the kinds of cases that we all have nightmares about. We have DCIS involving lobules with extensive lymphoid infiltrate in the stroma. When the invasive cancer algorithm was applied, there was a little area of red highlighted by the algorithm. And at high power, you can see that this corresponds to a minute focus of microinvasion. Now, microinvasive foci are minute, but this is a minute focus of microinvasion. So what's the future of AI in breast pathology? Well, the future is now, really. AI can provide improved accuracy, efficiency, and consistency for specific defined tasks like prioritizing cases, diagnosis and grading. We didn't talk about grading. Identification of lymph node metastases, quantitating histologic features and biomarkers, pre-ordering receptor stains and levels when necessary, and pre-populating reports. In the longer term, the AI algorithms will become more sophisticated and do things we currently can't do, and that's where there's going to be real added value. But ultimately, what we're looking for is integration of clinical, radiologic, histologic, biomarker, and genomic data to create a comprehensive computational pathology profile for optimal diagnosis, prognosis, and treatment. So I thank you for your attention.
Thank you so much for wonderful presentation. And lastly, I would like to introduce our last speaker who will speak about AI in gastric biopsies. I invite Dr. Adam Booth from Washington University School of Medicine.
Good afternoon, everybody. So thank you for the introduction. So I'm Adam Booth. So I'm going to be talking about our multi-site, multi-reader study on artificial intelligence-assisted primary diagnosis of gastric biopsies. All right. So just a little background. We're seeing increased cancer incidence, heavier workloads, increased, that gives an opportunity for increased risk of errors and diagnostic delays. I know I've had several conversations about turnaround time with people here, and the delays that they struggle with due to the lab. We're also seeing ongoing digitization of pathology. Departments, they're utilizing AI-powered solutions, and that can support pathologists, kind of like an augmented pathologist. So what was our objective really with this study? So we wanted to assess the accuracy of pathologists performing primary diagnosis using the Galen gastric compared to the standard of care. So it's digital slide review. And how did we go about this? So this was based on fully supervised, multi-layered convolutional neural networks designed to classify and analyze whole slide images. It was trained on over 1.4 million slides. And that was labeled and this was from different pathology laboratories. They were manually annotated by 15 senior pathologists. And it's trained to identify more than 35 different classes of pathology and benign changes in gastric biopsies. So what did our study cohort look like? So we had 235 cases, and these were enriched for carcinoma, high-grade dysplasia, high-grade lymphoma, and other non-neoplastic pathologies. Cases were retrospectively enrolled from 3 different laboratories, 1 in France and 2 in Illinois. Ages of our patients range from 19 to 94, and there was about a close to equal distribution of female and male subjects. So looking at some of our numbers, so the number of positive cases. So we had 58 cases that were either cancer or high-grade dysplasia or high-grade lymphoma, 20 that were neuroendocrine lesions, 21 that were low-grade lymphoma, 31 that were adenoma or low-grade dysplasia, and 36 that demonstrated Helicobacter pylori and related gastritis. So how did our study design work? So there was 2 parallel arms with a crossover design. So we had our digital review, so standard of care, looking at the digital slide, H&E, like we do in our daily practice. Whether it's digital or glass, of course, different. And the other slide, the other arm, the Galen gastric, so utilizing the Galen gastric with the digital slide, so the first read workflow. So we had 6 pathologists. They looked at 75 to 80 cases each, and these were based in the US and the UK as well as France. For ground truth, because there's always it can be some discrepancy, right? So it was determined by consensus between 2 subspecialists plus an additional subspecialist for discrepancies there. And then ultimately these were adjudicated, so determined major discrepancies between the study arms, adjudicated by 1 more senior pathologist as well. And again, in major discrepancies, I just want to stress, were described as those that impact clinical management. So like treatment impacts, or how or frequently they're going to see the patient again. So how do we define those? So major discrepancies. So detection of carcinoma or high-grade lymphoma, detection of neuroendocrine tumor or neuroendocrine carcinoma, low-grade dysplasia, suspected low-grade lymphoma, and detection of H. pylori and related gastritis. So actionable things that we want the gastroenterologist and the team to know about so that they can do something to prevent or to help the patient now or prevent something down the road that gets worse. Minor discrepancies, neuroendocrine hyperplasia versus normal, neuroendocrine tumor versus neuroendocrine hyperplasia, polyps or adenoma versus low-grade dysplasia, detection of intestinal metaplasia, and then gastritis versus normal. So how did we do? Well, we saw that it improved pathologist performance using the gastric Galen. So looking at that first, the top left there, the digital review, standard of care, and we saw a major discrepancy rate of 17.48, so almost 17.5. And then utilizing the Galen gastric, we saw a discrepancy rate of right at about 13%. So ultimately, we saw utilizing the pathologist with the Galen gastric, we saw a lower of major discrepancy by 25%. So where were those major discrepancies at? So kind of across the board, really, when you look at this chart here. So we found it lowered in all of them. So detection of carcinoma and high-grade lymphoma, neuroendocrine carcinoma, low-grade dysplasia, low-grade lymphoma, and of course, H. pylori and gastritis. So actionable things we want the gastroenterologist to either act on now or continue to watch or maybe watch sooner. So where were these discrepancies? Overcalls or undercalls? Well, we saw that Galen gastric lowered the undercall rate among all pathologies again. How does this really combine to demonstrate the accuracy of pathologists in cancer detection? Well, we see an increase in our sensitivity, specificity, as well as positive predictive value and negative predictive value. So you can see in the chart here on the left, specificity slightly increased, and our sensitivity, really increased quite a bit there. So, let's see. How does it perform with cancer detection? So how do we see our ROC here? So you can see an AUC here of 0.984, and so this is the Galen gastric itself functioning. So a sensitivity of 96.67%. and a specificity of 90.86. So that specificity, not quite as much with the pathologist combined, right? This is an example of one of those cancer cases here on the right. You can see that heat map like we've seen in the other presentations, highlighting this focus on the bottom right here. All right. Let's look at an example. So unfortunately, this is a case that was missed originally by the pathologist on standard review, but identified by Galen Gastric. So this was a case of signet ring cell carcinoma, and there's just a small focus there on the bottom left, and that's what you're seeing here on the bottom right. All right, so we performed this study, and I wanted to submit some other slides of myself to see how it worked on slides from different laboratories that I had, some of my cases, and really evaluate those. So I submitted those. I had them run the Galen Gastric on it, and so I've got some examples here I want to show you kind of how it would work, function in real time, real life. You know, different H&E stains from different laboratories, similar to what we had in our study, where, you know, the algorithm was applied to slides that were pale stained, deeply stained, different quality slides. So a lot of variability there, right? So let's look at a few cases I've had. So another gastric biopsy here. So we see an area there, it looks pretty busy, like pretty blue on the top. So applying one of our heat maps. So this is our H. pylori gastritis heat map. Let's take another higher power look now. Again, here's our H&E. Again, very busy, typical picture of what we might expect to see for H. pylori gastritis. And then looking at it with the heat map on there, you can see it nicely highlights that. Focal areas that are, you know, moderately suspicious, and then a little red in there too, right, for H. pylori gastritis. So just to confirm, here's our stain, and we can see it nicely highlighted by H. pylori. So it picked up very easily all this kind of distributed H. pylori gastritis pattern that we commonly see in our GI biopsies daily, right? Here's another case. So again, we fragmented. We see a couple of really dark pieces of gastric tissue here, kind of on the bottom left there, and then maybe pretty busy with maybe a follicle or something on the top right up there. Let's apply our algorithm here. So this is the high-grade carcinoma, high-grade lymphoma algorithm. And so we see on the bottom left that piece that looked busiest, probably had some crush artifact or something like that in there too. But let's take a higher power look at that area it's highlighting. Okay. So sure enough, a lot of crush artifact, but we see some really ugly pleomorphic cells there. I don't think it's coming through quite well for everybody, but so this was a high-grade lymphoma. So just thinking about that other focus that we saw of lymphocytes, looked a little more bland. So let's apply the low-grade lymphoma and see how that looks. So you can see it's highlighting that focus rather than the high-grade area that we saw previously. Take another look at that piece. You see pretty brand, kind of monomorphic lymphocytes, so not high-grade lymphoma right there. All right, let's look at another pathology case. So another gastric biopsy, maybe some more cautery artifact, little crush artifact, not uncommon to see, right? So we see maybe some nested cells there in the center, kind of expanding this lamina propria. Let's apply our neuroendocrine heat map. And so you can see very nicely highlights, you know, very high likelihood of neuroendocrine tumor. So sure enough, yes, a neuroendocrine tumor. So go to another case, gastric polyp I received. So even at low power here, you know, it looks like dysplastic polyp, right? So looking at it with our low-grade dysplasia heat map, the adenoma heat map, you see very nicely highlights all those areas that we're suspicious of on the H&E alone. And so let's think, is there anything worse there, high-grade carcinoma? So here's the high-grade or carcinoma, high-grade lymphoma heat map. And so there's an area there that we do see is highlighted, little red, bringing your attention to that, you know, really wasn't as apparent at a lower power. So let's take a closer look at that. So this is that same image, a little higher power. You can see those red areas. And so now I'm going to, you know, remove the heat map, and so you can see, so there are areas there, you know, nicely shows some intramucosal carcinoma in this large polyp, but pretty subtle on low power. So looking at another case, fragmented GI biopsies, you know, typically what we see. Let's apply our map. There's a high-grade lymphoma carcinoma heat map here. So we got several fragments. Again, we always get these biopsies that are like that. So you hope you get one that has some good, something diagnostic on it, right? So looking at our heat map, we've got some areas that we want to look at. We'll just pick out one there kind of in the middle to the bottom. So take a higher look at that. So we can see nicely highlighted some high likelihood foci of cancer there. So see what the H&E looks like there. So we've got, it doesn't display well, but now we can really see lots of signet cells there. So algorithm very nicely identified those sneaky structures. And if you go back to look at the H&E low power with the algorithm on it, you can see it highlights a lot of different areas there, kind of red, orange, small foci where that carcinoma is kind of infiltrating through. So looking at another case, this was actually a younger patient, vomiting, blood, gastric biopsy performed. So here we're looking at it with our high-grade dysplasia carcinoma heat map. We can see nicely some foci with high likelihood. So let's take a closer look at those. Again, kind of spread out and distributed as we've seen, kind of leaving out a little gap there, right? So what's that look like on the H&E? So we can see here, again, another invasive carcinoma, kind of poorly differentiated here. So looking at, gastroenterocolic for different lesions, so we looked at some carcinoma and some other examples. So for other lesions, other pathologies, how does it perform? So we see an AUC, well above 0.95 here for neuroendocrine lesions, low-grade lymphoma, all the way up 0.94, 0.95, 92, 97. So again, high performance on multiple different gastric pathologies that we commonly see in everyday practice. So some conclusions to draw from this. So it was significant. So Galen gastric was found significantly superior to our gold standard of care. So just simple digital H&E review for primary diagnosis of gastric biopsies. We saw that the major discrepancy rate utilizing the gastroenterocolic fell by 25%. The AI solution improves pathologist accuracy on cancer detection. It demonstrated high accuracy on different geographies. So again, France, Illinois, various parts of Illinois in the US, different scanners, different pathologists, different staining protocols. And the AI solution found to have the potential to be implemented as a screening tool to help pathologists really gauge and triage their cases in real time for decision making. So just as our previous presenters mentioned about triaging their cases, you can do the same thing with your gastric biopsies. Am I worried about cancer here? Do I need to order? I know in my institution we upfront order immediately gastric adenocarcinoma. We're going to order our biomarker stains and stuff like that. So how can this make you more efficient? Right there. Do you need to do deeper levels on some of these fragmented biopsies that we get to see if you can make a diagnosis of invasive? Maybe you can triage that case early in the morning, make sure you get those stains out on time. So I'd like to thank the institutions and different pathologists that participated in this study. And you can meet in Ibex booth 755.